Now we'll be discussing about a very interesting and important topic, that is edema. Now we know the edema is an extremely common problem and it's very easy and fast to diagnose why is the edema. So to find out, we can simply give sustained pressure over this area for around 10 seconds, and we can definitely see a pitting. So this is the tibial or tibial region where we can give firm pressure for around 10 seconds, and if there is pitting, we call it as a pitting edema. Now pitting edema is very common, and it is very easy and fast to find out why it is that why that is problem. So the drugs, one of the most common drugs which causes pitting edema is amlodipine and cilnidipine. So these two drugs very commonly cause edema. You can simply ask for history of edema or these drugs. Second thing, patients very commonly drink so much of water. So if anyone is more drinking more than 3 liters of water, most of the time, more and more the water they drink, very commonly the patient can get this type of pitted edema. In pregnancy, this is a physiological because in pregnancy, the blood volume or plasma volume increase to more than 1.5 times the normal, and because of the gravid uterus, it gives a constant pressure over IVC that can also cause bilateral pedal edema, and it is very common. Now coming to the heart, pedal edema is one of the earliest symptoms of heart failure, and this is usually seen in bilateral lower limbs. So, in such patients, asking history of diabetes is very important, hypertension is very important, angiography, angioplasty, it is very important, or a need of ventilator, it is very important. So, we should always ask for uncontrolled diabetes, uncontrolled hypertension, or history of angiography and angioplasty. Apart from that, if this is hard, one of the most earliest is bilateral lower limbs, and this edema keep on rising, and the patient may develop ascites later. Very commonly, the patient, if it is acute pulmonary edema or acute LVF, these people can very commonly have hypoxemia, bilateral lower lung field crypts, which crypts can increase and they can be found in middle lung fields as well as in upper lung fields also. So presence of hypoxemia, presence of tachypnea, presence of crypts, and presence of this bilateral pulmonary edema goes definitely in the favor of left ventricular failure, and such patients may have definitely reduced ejection fraction. So whenever this hard thing is coming up, we should always think of these diseases, hypertension, diabetes, and other diseases like other things which we should always do is ECG, 2D echo. Now in ECG, patient may show deep Q waves, patient may show poor R progression, patient may show LVH with strain pattern, and so many other things as well. So these things has to be always kept in mind. And whenever it comes to echo, the patient may show tricuspid regurgitation, mitral regurgitation, or significantly reduced ejection fraction, or regional wall motion abnormalities. These problems can be very commonly found in patients with heart failure or the patients who has this bilateral pedal edema because of the heart failure. We should be always thinking of these drugs also, whether the patient is taking or not, because this pitting edema usually responds excellently to diuretics like furosemide or torsemide. So most of the time, these patients, when they are put on like 10 to 40 milligram per day of furosemide or 10 to 40 milligram of torsemide, the edema simply disappear within a day or two. So other diseases like other organs which can definitely cause this type of edema is kidney. In chronic kidney patients, in chronic kidney disease patients, they can also very commonly have this hypertension, diabetes, history of angioplasty, angiography. These patients may also have uh, increased water intake, or these patients may be taking like 3 liters, 4 liters, or 5 liters of water. They may be taking a very salt rich diet like deeply fried foods, or some yummy foods, junk foods. So this type of food very commonly increase sodium, they increase water retention, and it very commonly causes pedal edema. So for kidney, one of the most important tests is definitely again ECG echo has to be done, because any patient who has this kidney problems or CKD, they can definitely have heart problems as well as that. Like for that example, in CKD patients, they very commonly tend to have high blood pressure or refractory blood pressure. So they can definitely have all the problems which are associated with the heart. These kidney diseases patients, they must undergo urine routine and microscopy, which may show proteinuria. So, if the patient has CKD, they are very highly likely to show the proteinuria that can be 2 plus, 3 plus. So, very commonly, protein loss, especially albumin loss, leading to hypoalbuminemia, also very commonly causes this pedal edema. Along with this, the presence of casts, presence of infection, presence of glucose, ketones also may help us to find and treat underlying CKD and other problems as well. One of the most important thing for this kidney diseases is sonography of the abdomen, because we can directly see the kidneys, and we can then try to find out whether the patient has pyelonephritis or emphysematous pyelonephritis, or whether there is raised cortical echogenicity or not. Because if the patient has raised cortical echogenicity, it usually indicates that the CKD or chronic kidney disease is already set, and the patient may have underlying hypertension, diabetes, or CKD since so many years. So for kidney, this urine routine microscopy, ultrasonography of abdomen, pelvis is very important to look for any renal calculi, ureteral calculi, cystitis. For recurrent UTIs, prostatomegaly, it is very, very important. And one of the most important thing is UPCR, that is urine protein and creatinine ratio, because until the patient does not have well settled CKD, the UPCR does not increase. If UPCR increases, it means the CKD is already set in. More is the UPCR, more is the bad chronic kidney disease, and it has to be aggressively treated with either a control of underlying diabetes, hypertension, or to find out the underlying chronic kidney disease causing disease like nephropathy or nephritis. Now, when we are talking about liver, very commonly liver failure or chronic liver disease, which very commonly has hypoalbuminemia, also presents with bilateral edema. So in that case, doing liver function test to see total albumin level, which has to be more than 3.5 gram per deciliter. So if it is less than 3.5 gram deciliter, it definitely suggests hypoalbuminemia, and that can definitely cause the bilateral pedal edema. So in that scenario, we should be always looking for presence of portal hypertension. We should be looking for ascites. We should be looking for spontaneous bacterial peritonitis, esophageal varices, if the CLT is the culprit or hypoalbuminemia is there. In that scenario, we should always do urine routine also to see whether there is any protein loss through the urine. And history of alcoholism, history of tobacco, or history of any other addiction also has to be kept in mind. So, drinking excess of water, poor salt and water restriction or compliance, these kidney disorder, heart disorders, all these things very commonly cause the pedal edema. Apart from this, the patient may have deep venous thrombosis. In that scenario, the patient will mostly only have a unilateral leg involvement. Most of the time, this calf will be swollen and calf will be tender. and this most of the time it will be always painful and swollen, and that history may be there for few days. Most of the time these patients will have some addiction of alcohol, tobacco, tobacco or hyperhomocystinemia, or these patients are very reluctant for the treatment, very less compliant with the treatment. These patients very commonly may have a diabetes mellitus, and they are very irregular on the treatment. So, in DVT, the patient will have usually unilateral swelling, which will be significantly much more than the contralateral leg or the other leg, and cough is involved. Here, one of the most important tests is USG Doppler of that leg, and this USG Doppler will directly can show us the thrombosis of these blood veins, or they can see the blood clots which are there in the deep venous system, so that these veins which are normally, as soon as we press a probe on that vein, this vein actually compresses. So if this is the vein, on compression this will become small, but whenever there is DVT, because of the presence of the clot, even if we press the probe from outside, even if we press the ultrasonography probe on that vein, this vein won't collapse because of the presence of the clot. So, incompressibility of these deep venous system or deep veins tells us that there is a clot. One more thing, suppose this is the great saphenous vein which is going here. So what we very commonly do, we put a probe here. We put a probe here, and what we do, we see the blood flow on putting this probe here. So normally the venous flow is very, very slow. But what we do, we put our hand over here and we simply compress this calf or leg by our hand. Because of this, the blood flow actually rises towards this side. So if the deep venous system is working normally, if there is no clot, this, because of the compression, we could see the blood flow which is coming towards the probe, because the veins are intact and there is no clot. But when there is deep venous thrombosis, when we compress by our hand, then because of the clot, the blood won't go up. So there will not be any change in the blood flow that will be appreciated by this probe. This is how we can definitely tell that there is deep venous thrombosis. So the unilateral swelling can be because of some bite, by snake bite or any insect bite or any animal bite, or it can be because of unilateral cellulitis of the or infection, which will be very commonly seen in those patients who have uncontrolled diabetes or diabetes. So patients with cellulitis very commonly have not only the swelling, but significant redness will be there on the cellulitis portion. There will be significant redness or erythema. There will be significant pain, and we can most of the time see ulcer also if it is there. But the cellulitis works or gets better much well with the antibiotics. So we always have to keep these things also in the mind. So for now, this is all, and thanks for watching. Good day.